Welcome everybody to this month's Midwestern University Physical Therapy Institute. Yet we'll be probably doing these beyond just our Physical Therapy Institute monthly talk. We're going to have a live stream today and talk a little bit about a topic. If you've been tuning in the past, we've had a few other topics. This month we wanted to talk about a common one that we see in the clinic around shoulder pain, specifically around rotator cuff issues. So we're going to get into that. But before we do, I want to just introduce myself. My name is Dr. Mark Kargela. I'm a clinical assistant professor here at Midwestern University. I've been with the university for 6 years, practicing in our Glendale location in our Physical Therapy Institute. My special interest is orthopedics. See a lot of shoulders on a regular basis daily in the clinic here. My primary role here at the university is to treat patients, but also mentor some of our fine students as they come through and do some of their mentored hours with us in the clinic. Tom, why don't you introduce yourself, sir?
Yeah, very similar. My name's Tom Dillon. I am an orthopedic physical therapist at our Downers Grove campus. Very similar role. A lot of my time is treating orthopedics, lots of shoulders, backs, all sorts of things. I started teaching a bit more on campus, which has been nice. A lot of orthopedic related content. We do a little research here as well. Special interest is mostly orthopedics. So pretty darn similar. I've been with the university for 8 years, I think. But yeah, I'm looking forward to this topic because shoulder pain is probably one of the most common things you and I see in the clinic. I mean, between that and low back. But just like everything we do, it's never an easy answer all the time. There could be 1,000 things, but I really hope that today, and really the whole point of what you and I try to do here is just anyone out there listening that has shoulder pain or has been told they have a rotator cuff tear, maybe there's that little pearl of wisdom or advice they can gather from this and helps them make decisions, or at least gives them encouragement that they're on the right track. And that's kind of our goal.
Yeah, I think it's one of those conditions that I think not a lot of great information out there on the internet, a lot of confusing information per with everything. Dr. Google can be our friend and sometimes not our friend, depending on who's providing the information. So again, hopefully we'll provide some information for y'all that are maybe dealing with some shoulder issues or know somebody who's dealing with some shoulder issues to maybe make some good decisions, some well-informed decisions on what's going to best move you back to the things that are important in your life. Thought we'd talk a little bit because it's one of the things I think that's not well understood is just how common rotator cuff tears are. Tom, do you mind speaking to a little bit about how common rotator cuff tears are when we look at it in the literature and just how often we see it in people?
Yeah, I mean, in the grand scheme of things, it's common, but the variables you place on that can really change that percentage. And really, from study to study that have looked at this, it can vary. But there is a general consensus that as we get older, it becomes more common. What I find interesting about a lot of the statistics that you do find out there about how common rotator cuff tears are is that oftentimes the data is collected from non-symptomatic shoulders, people without actual pain. And that really will tie into a topic Mark and I are probably going to touch on a bit later of what that may mean regarding pain and the tear. But from the data that tends to exist out there, it's pretty well understood that each decade from 50 plus, we start to get higher percentages of rotator cuff tears. One study was suggesting that about 13% of individuals at 50 or older, about 20% of individuals 60 or older, and 30% at 70 or older. Another study was suggesting upwards of 50% if you're over the age of 50, or over the age of 80. So there is a correlation between age and presence of tear. But I really think this gets into something, again, we'll talk about is the presence of tear does not always equal dysfunction, does not always equal pain or limitations. It may just be something that has been identified on an image and is not quite impactful, although many times it is. So.
Yeah, I think that's where ideally a good skilled evaluation on the shoulder to determine it, and versus, we always tell our students we treat people, not their scans, because sometimes those scans are meaningful clinically and sometimes they're not, but that's why a nice thorough clinical evaluation will help us kind of get to maybe some understanding of how relevant those images are. But I think just to echo what you said, Tom, the understanding that these tears happen in people that have zero shoulder pain whatsoever, that they may relate a past bout of shoulder pain, or maybe they tweaked or injured a shoulder, but sometimes people have zero background of any shoulder problems or pains, yet when we look at studies, they have presence of partial, even full thickness tears And these are people, again, who are functioning 100% without really any major limitations. They're not seeking any care. They're not doing anything. They're just moving on with life. So it's just important to know, because I think there's a lot of folks that hear the word rotator cuff tear, and immediately, I think, from the patients I talk to and just even friends and family members are like, oh, surgery, which, again, we'll talk to. There is a time and a place. We're not by any means saying there isn't a time and place, but conservative care stacks up quite nicely against surgery when we look at it in the literature, when we compare groups, and we will speak to that probably here at the end. Tom, you alluded to it a little bit earlier, but the risk factors around it, age being one that we discussed already. Any other thoughts you have on like risk factors, things that might predispose somebody to possibly having a rotator cuff tear?
Yeah, absolutely. I think one good distinction that anyone listening might want to have is that there are often two ways the rotator cuff is torn. It's either a degenerative tear or it's a traumatic tear, like trauma happens, an accident, a fall, whatever, or over time. So you can see how over time things change, our bodies age, that's where these degenerative tears occur. And that's where kind of why age can be such a obvious risk factor for that. Smoking, they found that smokers tend to have more prevalence of rotator cuff. Smoking inhibits healing. It is involved in a lot of negative processes in our body, inflammatory processes, all sorts of things that we're aware of. But there is a statistical correlation. Those that smoke have a higher risk of having a rotator cuff tear. And one other major risk factor, at least in the data I was looking at, and I certainly see this clinically, is posture related. There's one study that suggested tears were present in 65% of people that had this excessive kyphotic and cervical lordotic posture, this forward head posture. And we can talk mechanically why that might be the case. Whether it's truly 65% or not, and again, correlation does not equal causation. Just because someone has bad posture doesn't mean they're going to tear the rotator cuff. However, it doesn't help. And how many times with all your patients are you addressing their posture? So that is a factor that did pop up when I was looking at it.
Yeah, I think the other thing I would think is just a little bit about like the person's history of how they're using their shoulder. Like if somebody's an overhead manual labor, I know I've worked with folks who do drywall or do things where they're up and loading their shoulders overhead and doing a lot of high impact things. One thing I'll talk to, we see a bit of some athletes, not maybe a ton, but Dr. Andrews, who's like the famous shoulder surgeon in the world of like athletics. So all the professional pitchers and quarterbacks go to see him to get their rotator cuffs repaired. And he was quoted, I think, in a lecture that said, if you want a reason to operate on somebody for rotator cuff, just take an MRI of their shoulder, you're going to find stuff. Like they're just very commonly, especially in overhead athletes who are doing a lot of throwing, but also overhead industrial athletes or folks who are using their vocation might require them to be doing a lot of heavy manual lifting and overhead stuff where there's quite a bit of demand on the shoulders. So yeah, that can be something that predisposes.
That's a good point. I mean, occupation or sport is definitely a risk factor. I mean, there is a statistic out there, and I wish I was better prepared to have it in front of me, but about those that, speaking of athletes that do get a rotator cuff repair of, within a year or two, how many of them have retorn and are still functioning? It's a surprising statistic. I'll have to look it up. Maybe next month I'll remind everyone. But
yeah, no, that's a good point you bring up. There is some actually interesting things that even the repairs that are successfully this person's rehab back to sport, that when we take a peek at MRI studies and stuff after that sometimes those repairs fail despite the person being back to athletic performance. So that's interesting. You spoke a bit to posture, and we touched upon it a little bit about posture matter. And so we maybe won't beat this one up too much more, but I would echo what Tom says. It's not an everybody posture matters type thing, but if oftentimes we will check that clinically where, if somebody's function significantly improves when we start working them back into some, we call it pulling your shoulder blades back or scapular retractions, the fancy PT term, or working some extension through the mid back or your thoracic spine, and it improving shoulder range of motion. There's just a chain of movement that physical therapists are pretty well educated on to kind of look at what are the areas around the shoulder that if they're not moving well, if they're not functioning at their optimal abilities, that it could negatively impact the shoulders. So posture and like position of the neck and mid back can definitely be one of those that we'll evaluate and then see, can we intervene? And again, it's not something where every patient needs to, be sitting up or rigid like a board, but if there's some things we can see that when we address those things, there's a definitive improvement in function and improvement in shoulder work, then that kind of speaks for itself in our opinion. So anything else you wanted to add about posture, Tom?
No, I think anyone sitting out there, if you just even do a trial where you stick your head forward and try to raise your arm up, it can't go very high. But as soon as you sit up tall, you get all this, 30 degrees more of motion. I mean, that's pretty telling for a lot of my patients. It just creates a cascade effect of immobility that can really wear down a rotator cuff.
Yeah, that's one I'll often do with patients to talk to them and why they would benefit of working that, where you have them slouch, raise their arm overhead, and then you can all do it at home while you're watching this. Give your best slouch possible and try to see how high you can raise your shoulder. Then sit up tall, see how high you can raise your shoulder. There's a lot more freedom of movement when we're in a little bit better position when it comes to that. So good point there, Tom. Another common issue or common question we have, I've had family and friends who have shoulder pain and they've read something on the internet and they're worried they have a rotator cuff tear. Now, again, we'll talk to some of the nuance behind that discussion, because there are some times where maybe imaging definitely, and then sometimes where it's probably not necessary. Tom, can you speak to a little bit? We spoke about it before we went on here as far as imaging. What are the situations where somebody comes into you clinically where you're like, we probably need to get that image, versus, hey, we can probably move forward without any imaging at this time?
Yeah, I mean, this goes back to the types of rotator cuff tears, or at least the mechanism of injury. So one pretty easy example would be if someone comes in after a trauma, and because in all our states, we have some degree of direct access, physical therapists can be the first line of defense someone comes to because of an injury, which is a very positive thing. And we're nicely trained to understand, do we accept this and treat it? Is it within our scope, or do we think that there's something else going on we need to refer out? Well, a particular situation in which someone had a trauma and they come in and they can't raise their arm, they fell on it last night, whatever, it's in our best interest to have them get that image. We need to rule out a fracture. We need to rule out any dislocation. And certainly if there's a rotator cuff tear that's trauma related, those are often the ones that do best in surgery anyway. So I think that type of situation requires a referral, requires imaging. But and certainly we have our thoughts on imaging in general. And I don't know if you want to kind of speak to that as well, but I am a fan of imaging. I think it has its place and can guide things. But in the case in which a trauma occurs and you're there with that patient, I'm certainly one to recommend getting imaging before we proceed.
Yeah, I would echo that. I think just the traumatic acute injury population with significant disability and different things, I would say for sure that would be something where recommending imaging, communicating with primary care providers and things. Nice that we have the opportunity at Midwestern to often communicate with our colleagues in our osteopathic medicine division to help that stuff along and help somebody, kind of make their way into the appropriate imaging if needed. One thing, I'm going to put a couple of questions on here and we'll get back to a little bit more of the imagings. Steve had asked a question, our friend over in Downers Grove, about alcohol consumption when it comes to risk factors. Can that impact shoulder health like smoking does? I can't speak to that specifically. I'm not aware of any specific literature on alcohol consumption as specific to the shoulder. I mean, just in other metabolic health conditions and things like that, I think it would make sense that it probably isn't the excessive alcohol consumption probably isn't in general overall health, but I'm not aware of anything particular on the shoulder front. How about you, Tom? Anything that comes in?
Here's a situation. You can imagine a trauma of a rotator cuff tear happening because you drank too much and you fell down. So maybe indirectly, but yes. I mean, overconsumption of alcohol has its major health concerns. Whether it can be directly related to a rotator cuff tear, I'm sure there's a cascade of events regarding some of that stuff that we could pick apart. But really what popped out for us was definitely smoking in terms of the healing of tissue. Yeah. So.
Marion, thanks for asking your question. How long is recovery from shoulder surgery? Good question. It's there's not a really one size fits all answer on that. It depends how involved the surgery is. Like for instance, for a rotator cuff tear, that surgery can be wonderful. It is on my top 2 or 3 list of surgeries I hope not to have, not because it doesn't do wonderful things and can't be an amazing outcome. It is just it is a cranky rehab. It is pretty sore. You're not able to use your arm actively very much for the first 6 to 8 weeks, sometimes longer, depending on how much repair work needs to be done. So it can be a slog. I mean, I think anywhere from, generically, if it's a very minimal small tear that's not very highly involved surgically, sometimes you'll hear docs say, 3 to 4 months, and then maybe all the way to 6 to 8 months if it's a more involved surgery. So those are just generalities. Anything you'd add to that?
Yeah, I think it's just a good opportunity to talk about the rotator cuff really quick, because you had mentioned that there is a variety of types of, how involved is this surgery? How involved is this injury? I mean, there are 4 rotator cuff, and the unofficial bicep is your 5th rotator cuff muscle, meaning, just because someone says they have rotator cuff surgery, you don't know if they had a simple, small, little partial thing going on with one of those muscles, or they had 3 tears, and they all do different things. So you can imagine someone has 3 rotator cuff muscles affected, they're going to have a longer recovery. And we are dealing with muscle tissue, contractile tissue. There's a lot of safety we got to take around that, because we have to let that tissue heal before we challenge it. And so then you got people in slings for, 6 weeks. We can't really start resisting stuff until, 10, 12 weeks sometimes. And it is a long process. I wouldn't be happy to have one, but they are very successful when they're appropriate, and they are great surgeries. So anyone out there that is planning on having one, this is not to say that it's discouraging, but have your expectations. You're going to be in a sling for a bit, you're going to be sore for a bit, and there's a healing process, but find yourself a good PT and you'll be happy.
Yeah, I mean, we're obviously speaking from a biased lens here, but one that's pretty well founded in evidence of, conservative care usually is your first stop. A lot of our orthopedic colleagues who we have good relationships with are going to, if you go to them acutely or with a rotator cuff tear that hasn't been through physical therapy and it's not a massive acute trauma, that they'll often send you to PT for 6 to 8 weeks before they entertain surgery, just because a lot of those folks will recover well without their necessary. Orthopedists really want to make sure they're operating on the right patient oftentimes. So yeah, good points you make there, Tom. Just to come back to imaging a little bit, because there are patients who sometimes will say, well, I don't know if I should pursue PT unless I have my image, so you know exactly what's going on in my shoulder. Can you speak to that, Tom, as far as our thought process on where imaging fits as far as guiding our treatment and how it will change or not change what we do?
Yeah, I feel like this has turned into a common theme with our talks, imaging and I love imaging. I've mentioned before, I like doing diagnostic ultrasound and biofeedback ultrasound in the clinic. That's always kind of a nice way to get real-time muscle images and tissue images and so forth. In terms of images in this situation, oftentimes, unless it's that trauma situation, that usually is us sending them off saying you need to get this X-rayed and MRI just to be safe. Especially with the degenerative tears, they've seen the doc, they're coming in for PT, conservative treatment. To me, imaging is not going to change my plan. Physical therapy, we often treat what we see. We treat what's in front of us. We treat the body, the joints above and below. We kind of work together and kind of as a whole group. So just because I know it's a torn, my exam is going to suggest it anyway, and I'm going to work with what I got with what's in front of me. So long story short, imaging is probably not going to change my plan of care much with a patient unless we hit a wall or I think something else is going on that we need to get an outside look at it in those chronic cases, especially, or the degenerative cases.
Yeah, I would definitely agree. So another question people have, well, what does treatment look like for a rotator cuff tear? Because there's understandable concerns people have about engaging in exercise and doing things. And we'll talk to some of the reasons behind exercise with it. But general treatment, obviously, first is started with a good evaluation of seeing exactly, where limitations, impairments, and maybe range of motion, strength, where there might be some, signs of inflammatory components. And then it becomes designing a program that might involve some passive manual therapy type techniques to help restore range of motion, to help get people moving with less pain, and then eventually a graded loading or strengthening program to get the shoulder back into the things it's currently weak or sensitive to. And those are usually targeted on specific to the unique individual of where their movements are weak and limited, and then what are the demands of their life? What do they need to get back to? Are they the drywaller that needs to eventually be pressing, sheetrock overhead, or are they somebody else who just needs to be, pushing doors open or different things? So we want to make sure that it's a tailored, individualized approach with that. But it's kind of the range of motion, strength are probably the two bedrocks of it. Anything else you'd add to that, Tom?
Yeah, I mean, if you're seeking treatment or about to get treatment or whatnot, expect to have them put a lot of effort into strengthening of your deltoid, the intact rotator cuff muscles, their scapular muscles. You're going to be doing a lot of these exercises that promote this retraction, your mid trap, your low trap, kind of create this downward position of your scapula so that you're not rubbing on that rotator cuff too much. And as I mentioned before, don't be surprised if your therapist decides they want to do a little mobilization to your thoracic spine, or maybe work on your cervical spine a little bit to get that alignment appropriate for good shoulder motion. It's all very reasonable. So. Typical.
Yeah, no, good points. Good points. The exercise thing, a common thing people come into us with is like, I have a tear. Why on earth would I exercise a tear? It's going to make it worse, will it not? And I'll start a little bit, and I know, Tom, you have comments on it as well. As far as there's a quote, I don't remember who it was in our profession that said it, but we're really strengthening the donut, not the hole. So we can't untear the part that's torn, but we can reinforce and strengthen the existing fibers and strengthen the areas. As Tom mentioned, there's multiple rotator cuff muscles. You have a deltoid muscle, biceps muscle around that can really compensate, as evidenced by the people that carry these tears around and are compensating well with full function without problems. So exercise will not increase a tear unless there's traumatic exercise. If you drop or fall off a table or do something like that, that would tear, shoulders, regardless of if they had one previously or not. But in general, exercise is very safe. And in fact, exercise is probably one of the best things to start getting your shoulders less sensitive to loading, to reaching, to lifting, through working slowly into exercises that strengthen your shoulder into it. So what starts very sensitive and weak, as you build up a strengthening program that targets that area with the rotator cuff that might be torn, it eventually becomes something that, when we see the outcomes that often happen, that what starts sensitive no longer is sensitive, and that person's back to lifting, reaching, pushing, pulling, pressing, all things shoulders do without that sensitivity that was initially there. What would you add, Tom?
Yeah, I mean, that's all perfect. It's that loading response, and that gradual progressed loading is really important. I think it also gets the idea. It's really funny to me that physical therapy often, or injuries often, start with rest. Oh, you got to rest it. At least that's how we used to treat it. And then as evidence comes out, you're like, well, maybe movement's good, and then all of a sudden you realize, well, yeah, actually, if we get them up and moving after this surgery or this injury, they do better than if we make them lay in bed all day. So it's just a funny trend that we see. The rotator cuff is no different. I mean, it's going to involve the joint. It's going to involve the muscles surrounding it. And we're going to be addressing all that, and that progressive loading of those intact muscles are going to be incredibly helpful. Because as we know, we're not going to fix that tear. There is a chance that even if the tear was repaired successfully, I'm not going to say the surgery has failed, that down the line, there would be evidence of a re-tear, but they're functioning normally. How are they functioning normally? Well, they've addressed the strength in all those other areas appropriately. So, yeah, I think that's a big one. I also, this might be a good opportunity to talk about your views, Mark, on what a pain response should be. And I really think that this is not just specific to rotator cuff rehab. I mean, can be applied to a lot of things, physical therapy. Is it okay that I have a little pain with my therapy? And, before kind of you give your comments, the one thing I'll say, I am not a no pain, no gain clinician. I don't think that that's really appropriate, but there is an appropriate degree. And it really sometimes is about the patient understanding, what do I mean pain, or do I mean soreness, or do I mean the stretching sensation? And really kind of defining that a little bit can help. But what are your thoughts on that response?
Yeah, I think that's a key one, because even some of the research that's come out that's looked at, if we make a rule where exercise is not to be done if there's the least bit of pain, so it has to be 0 out of 10 throughout exercise, and then we compare it to a group of people where we say, hey, you can work into a manageable degree of soreness, obviously nothing severe, and we compare the outcomes, the folks that are given permission to work into a little bit of soreness tend to do better in some of the studies that have been done. Which makes sense too. We can't overprotect a body part, be it a rotator cuff or a back. And I think sometimes we see some of the chronicity of some of the conditions we see that are lasting beyond tissue healing times are because some people have adapted behaviors where they're avoiding and not using the body part. And then when it does get called upon, it's not at all trained to where it's going to tolerate the load or demands that we're trying to place on it. So the thing that I tend to tell folks is, a generic rule that even the literature talks about is like a 4 out of 10 on the pain scale. that goes away within 24 hours is usually a good kind of rule of thumb to think about when it comes to like soreness after exercise. And really making sure we try to have those discussions with our patients, because they're obviously understand that anytime soreness or discomfort happens, the concern understandably like, hey, did I worsen my tear or anything like that? And again, we're not worried about worsening tears with we don't do any dynamic or anything that would threaten the integrity of that shoulder tissue. But it's something that's important to being willing to nudge into that sensitivity is almost what's going to help that sensitivity decrease more rapidly over time versus waiting for everything to feel perfectly 0 out of 10 before we move forward. What are your thoughts, Tom?
Yeah, I mean, there's plenty of conversations out there on pain neuroscience, and there is a normal degree of discomfort. I mean, you can wake up and your knee's uncomfortable a bit. I think the key words that you described, I want to reiterate because I use them as well, and I try to teach patients, is the 24-hour rule. You know, does it calm down? Does it resolve in 24 hours? And was it tolerable? Was it that 3 out of 10, that 4 out of 10 you tolerated, you went and lived your life? Or, you know, and that really kind of can help judge, did we push it too far? And so on. So yeah, soreness and sometimes pain can be a normal response, but it's really how we describe it that is going to matter if we overdid it or not.
Yeah, Kristen commented, can you resume full exercise activities, specifically lifting weights after shoulder surgery? Yes, the answer to that, and that's something we commonly work with people on. A common desire is to get back to the gym after you've had a shoulder surgery or get back to sport or whatever it may be, but weight training specifically is definitely safe. And I think a lot of people would argue the more you keep strength in your body to tolerate the loads that we put upon it, when you get called upon, I think sometimes the shoulders and things get in trouble because we're the weekend warriors, where we're sedentary throughout the week and not doing any weight training or things to keep our tissues robust and strong and able to take on strain. And then we go out and do 8 hours of yard work, lifting landscape stone and things like that. And then, our body's not prepared. But yeah, that's a common thing we'll work with people to get back to after shoulder surgery, is getting back to being able to lift weights and do the things that are going to keep a robust, strong shoulder moving forward. All right. One last thing, and this kind of goes in with what Kristen had asked about, but when should shoulder surgery be considered? Because hopefully you've heard today that we are definitely not against surgery whatsoever. We refer people for surgery once we've trialed physical therapy conservatively before we jump to that surgery. Or there's sometimes where, as Tom mentioned earlier, if the patient comes in after an acute, pretty significant trauma, direct access, we're the first practitioner seeing them, we're going to often recommend imaging and sometimes surgery if it's a pretty acute, nasty tear or obviously a fracture or something like that. That's something that probably needs to be intervened with, surgically, acutely. What would you say about surgery, Tom?
Yeah, it's a lot of factors to consider. I mean, if failed conservative treatment is the common phrase, often can be a somewhat of a pathway to surgery. And depending, I know a lot of people out there, and certainly our PT students hate when we say it depends. It depends. It depends. It depends. Well, I'm sorry, but it does. A lot of factors go into it, and really a lot of my job when I'm deciding that with a patient is, what is their ultimate goal? Are they 80 years old and they just want to be able to, play with their kids and go shopping, and their pain is not severe and their function's okay? I think that's something to consider, of whether or not, and is the tissue healthy enough to survive a surgery anyway, versus someone who's, a young athlete and they're traumatic tear in their 20s and they can't lift their arm. I think that there's something to be said about maybe pushing more towards surgery. So it's not a one-to-one answer, but I do think taking in all that to consideration, what is your quality of life like? What is your function like? And what is your ultimate goal? And back to when I said failed conservative treatment, I'm a big fan of, if I fail at treatment with someone, let's say with a degenerative rotator cuff tear, then my advice to them often is, unless there's a reason to rush into surgery, my advice is try some PT with my colleague or try some PT with another therapist. Get a different approach, get a second opinion, get something other than what you've worked with me for 6 weeks without progress. Let's try something different. And I think that often can lead them on the right path as well.
Yeah, very good points. I would echo that. Of course, a time and a place for surgery, but often conservative care is a good first stop in the road, in the journey with that. We're going to leave it at that today. We really appreciate all of you who've tuned in. If you're watching on the replay, we'd love to hear some comments in the comments section. Any questions you have, we'll definitely be responding to those. We'll be doing these monthly going forward. So if there's any topics you'd like us to discuss, anything else that we can talk about that would help you in your healthcare journey, definitely drop a comment in the comments below, and we will definitely touch upon those in the future. But we wanted to thank you for your precious time today. Hope you have a good rest of your day and take care of your shoulders.
Thanks, Mark.